Hi, everyone, and thank you so much, Dr. Mizrahi, for that nice introduction. And I appreciate everybody staying around till the last session of the day. All of the sessions have just been wonderful. I'm really impressed, and so many of the original investigators presenting. And I have to say that mine is going to be a very clinical talk and was a pretty broad topic, optimizing care in epilepsy. So what I tried to do is bring the most recent updates for epilepsy clinical care that I just received at our International American Epilepsy Society meeting. And that's why I really appreciate doing the winter conference because it's always nice to be able to bring the newest information. So with that, I'm going to start and really, again, focusing on current practices and bringing the past insights and future prospects where I can. I really have no disclosures. I have one event that is just so dear to me, and that's working with UCB on a special committee to select scholarship recipients. I don't think I actually have any disclosures. Um, oh, there we go. So the first thing I want to bring up, and I don't know if people have heard, but there have been some warnings by the FDA, actually change in the package insert for lamotrigine. And this actually came out in October of 2020, but it wasn't really publicized, and it was specific to our FDA. No other countries or organizations brought up this warning, but they changed the PI to discuss the possibility of delayed cardiac conduction, widening of the QRS, and the possibility of induction of arrhythmias that included sudden death at therapeutically relevant concentration in those with structural heart disease or myocardial ischemia. So this was shocking, and of course, lamotrigine, Lamictal, is the oldest of the second generation medications approved in 1994. So that was really, for me personally, that was really disruptive. And for everyone, we're going to have to take a different look now at how we approach anti-seizure medications with our patients. What initially they said was that we should avoid the use of lamotrigine specifically in those with underlying cardiac abnormalities, structural abnormalities, ischemia, injuries, susceptibility to arrhythmias, ventricular arrhythmias, known conduction issues like specifically second and third degree heart block, and genetic sodium channelopathies like Brugada's syndrome. So the reason that this actually came about, because I thought, like many of you probably thought, why is this coming up now? I mean, this drug has been available since 1994, and we have so much practice and use of this medication. But I think the impetus for this was an in vitro study in 2011 by Harner et al., demonstrating lamotrigine acting as a class 1B antiarrhythmic drug, which actually, as I'll look at the past insights, we've known about this with sodium channel blockers in the past. But this in vitro study actually raised a red flag, and it was done in different manner than most in vitro studies are done, not on single cells. So we really don't have a lot of studies in humans with epilepsy. Studies in healthy humans have shown no increase in the QRS or shortening of the QT interval or development of arrhythmias. In those with cardiac disease, we're not sure. This really hasn't been, again, tested in vivo. And what about the other sodium channel blocking anti-seizure medications? Well, they will be investigated now. The FDA called for, in March of 2021, called for all of the sodium channel blocking anti-seizure medications to undergo investigation as well. So the AES convened a committee comprised of neurologists, cardiologists, and cardiac physiology researchers to provide guidelines and review things for us. So the review of studies of Lamictal lamotrigine showed no increase in cardiac arrhythmias or sudden death in patients that were on lamotrigine compared to other anti-seizure medications when you review all of the studies. Now, realize we're saying sudden death here. There's no increase in sudden death, but remember, with refractory epilepsy patients, SUDEP rates are fairly high. So there may actually be some sudden cardiac deaths that are in there that were missed and attributed to SUDEP. And I put in parentheses here the epileptic heart. We are beginning to realize now that there are features, structural and functional features of the heart in those with epilepsy, chronic epilepsy, not even those with refractory epilepsy, but just with chronic epilepsy. And I don't have time to go into that today, but we are beginning to look at all of these changes, which may make those with chronic epilepsy more prone, more vulnerable to sudden cardiac death. And this may be an underlying mechanism of SUDEP as well. So the lamotrigine finding is a dose-related effect, and it's seen at high therapeutic doses, but also at high levels. I happen to be a level physician. I check levels, and as I'll mention later, that's important, especially for women with epilepsy who are of childbearing age, so that you know what is their control level and what you're aiming for during pregnancy. So this, I think the main thing that the AES committee stressed is that this isn't a reason to go and take everybody off of lamotrigine or change your prescribing patterns. I don't think that there's any evidence that there is more risk with lamotrigine than there is with any other sodium channel blocking agent. Just in particular, this is the first anti-seizure medicine to be tagged. So as we all know, lamotrigine is still one of the best choices for new onset seizures, women of childbearing age, for the elderly population because it is gentle and has other benefits. And as I just mentioned, it's beneficial for the treatment of comorbid depression and anxiety as well in our epilepsy patients. So one of the first things we think about is, well, should we be getting an EKG on every one of our patients? And actually, Dr. French, Jacqueline French, who is on this committee and reviewing this for us at the AES meeting, said, we have enjoyed being able to just pick and choose our anti-seizure medications without worrying about other adverse effects in other organs like the heart, and many other subspecialties of internal medicine frequently do obtain EKGs and check cardiac conduction before putting on medications. So this might just be the new way for neurologists and epileptologists to proceed. But in general, there's no worry if a person is less than 60 and they have no cardiac risk factors. The time to get an EEG would be if they're older than 60 or any age with known susceptibilities for arrhythmia, structural heart disease, for example, or other known cardiac risk factors. And this is where I sort of say, this is not in my ballpark, but other risk factors such as diabetes, hypertension, hypercholesterolemia, and smoking, I think I personally feel that I would, at that point, recommend, or I myself would get a cardiology consult. And I think that will initially here be easiest for all of us as well. Um, if that is the case, though, and you feel you do need to get an EKG, it's best to do it before you start the titration. But as we all know, you do have to go slowly with the lamotrigine titration. And so you can even start your medication and then get the EKG in the early phases of the titration where the dose is low, because this is definitely a dose effect. And then they suggest maybe repeating the EKG at your target dose, or actually, this is important, if there's another sodium channel blocking agent on board, or I would also say if there's any other conduction blocking agent in use simultaneously. And then guidelines for a cardiac consult. If you have a person with known AV block, especially second or third degree AV block, but I would say even first degree AV block, and of course, no pacemaker already on board. If you have a patient with Brugada syndrome, which is a genetic disorder of the sodium channel, I actually have a patient with Brugada syndrome that I've seen for decades, probably 20 years, and thank goodness, I just think, thank goodness I didn't put him on a sodium channel blocking agent originally. But I think, in retrospect, we shouldn't, as I said, change our ways of practicing. If someone has an arrhythmogenic ventricular cardiomyopathy, a left bundle branch block, or even a right bundle branch block if it's complicated with a left anterior or posterior fascicular block. So that's as the fascicles go down into the ventricle, there is a left anterior and posterior fascicle, and that can sometimes be involved in a right bundle branch block. But of course, I would need a cardiologist to help me out there. If the person is already on a sodium channel blocker and has those above conditions, I think definitely you should get a cardiac consult and consider either using another medication or see what the cardiologist tells you about the sodium channel blocking agent. And this last one is a definite guideline. If there is a sudden onset syncope or presyncope that occurs without a clear vagal or orthostatic cause. And actually, this is really difficult because you think about all of the patients that have dizziness on anti-seizure medications, especially sodium channel blocking agents, and it becomes very difficult. But I think we can use our clinical acumen, and as we do in any event, ask whether this is vertigo or presyncope, lightheadedness, if this seems out of the normal realm of their usual presentation with their seizures. And that's where I have to admit I've gone back, and there have been patients who have had syncopal episodes, and this was before this was known. And I've gone back in those patients and checked it out with cardiac consult. I've had some patients that have had to be monitored. The problem inevitably is that there's not enough frequency of these types of events to catch it on monitoring. So it really will need corresponding with the cardiologist to help you figure this out. But I definitely had a patient, a young woman who was a nurse, and called me and said she had an episode of fainting. Now, that's not how she usually described her seizures, but I initially thought, oh, okay, that's a seizure. You've had a seizure. And she argued with me and said, no, this is not my typical seizure. This was a faint. I know the difference. She was a nurse, of course. And the other thing I did initially was, she's a young single woman. I thought, oh, you're pregnant. So I got a pregnancy test. and checked her level. And that's something, another reason why I think checking levels, which has always been my practice, should probably become one of your normal practices, especially with these agents. And it turns out her lamictal level was fine, but I did get an EKG, and it was abnormal, and she has gone for cardiac consult. I haven't changed her dose of Lamictal as yet because she has not had further episodes. What I did do, and this has not been suggested by anyone, but after dealing with this for a year now, I have discovered that in some patients, especially those who are on the extended release formulation, and I give them the full dose in the morning so as not to cause insomnia as an adverse effect in the evening, I have begun splitting that dose. It actually helps for seizure control as well, even though it is an extended release formula. So that is what I did with this young lady. I split her dose. She's on a fairly high dose of 300 milligram extended release, 2 in the morning, and I split that to twice a day, and she has been fine. So with lamotrigine and other sodium channel blocking anti-seizure medications, the risk of a problem with cardiac conduction is low, but it's not zero. As I mentioned, you should consider the risk to benefit ratio as we do with everything in medicine. And again, this FDA change was limited to the FDA, and no other regulatory agencies have brought this up. And just to give a little bit of past insight and a little future direction, as we know, past anti-seizure medications, which are sodium channel blockers, we already knew that there were difficulties with cardiac side effects, such as with phenytoin causing bradycardia, even cardiac arrest, and other conduction issues when the level was toxic, and that IV monitoring, IV administration required monitoring. Same thing with carbamazepine. There were similar revisions to their PI in 2018 regarding AV blocks and treatment with carbamazepine. How about with the newer anti-seizure medications? Oxcarbazepine, eslicarbazepine, for some unknown reason, they do not carry this warning. But as I said, they are currently having to undergo investigations looking to classify, that's what the FDA recommended, classifying what type of antiarrhythmic class these drugs would fall into and how they affect cardiac conduction. And then newer drugs like cenobamate and rufinamide, those definitely have a contraindication for use with those with familial short QT syndrome. And they do shorten the QT interval. Other newer drugs, lacosamide, which we all use, or at least I use fairly frequently. There is, again, a dose-dependent prolongation of the PR interval, and first-degree AV block and VTAC rarely have occurred, causing asystole, cardiac arrest, and sudden death. That was just added to their PI in October of this past year, 2021. So again, use with caution in the same set of circumstances: structural heart degree, AV block, 6 sinus syndrome without a pacemaker, myocardial ischemia, heart failure, Brugada syndrome, patients on other channel blockers like calcium channel blockers, beta blockers, potassium channel blockers, or other meds that increase the PR interval. And again, an EKG should be obtained before initiating therapy and monitored during IV administration. So I'm going to switch gears now and switch to one of my favorite topics, update of care on women with epilepsy, and that includes counseling women with epilepsy throughout childbearing years and before, pregnancy monitoring, breastfeeding, and maybe a little bit of the monid study by Dr. Metter and Paige Pinnell. That's maternal outcome and neurodevelopmental effects of anti-epileptic drug study. So usually I counsel patients on um, the major issues, which is primarily major congenital malformations. But I think now with the newer data that's coming out from some of these longer term studies, we should be talking about the cognitive development of the infant and even eventually child based on the anti-seizure medication that a woman with epilepsy is taking during pregnancy and even before pregnancy. Um, and we have more data now that we have international registries and we're beginning to combine data, which makes the most sense because we still have low numbers of pregnancies with some of the newer anti-seizure medications. So the registries are mentioned there, the North American Anti-Epileptic Drug Registry, EURAP, which is the international registry, the Australian, UK, and Ireland registries as well. And so the latest numbers show that, as has been for the past uh, years, valproic acid is associated with the highest rates of major malformations, major congenital malformations, 7 to 14% if you combine all the registries. Phenobarbital also associated with high rate of cardiac malformations in particular, and that's noted most, I think, in the North American registry. Lamotrigine has rates of major congenital malformations that range from 1 to 5% if you are looking at the combination of all the registries. But if you're looking at the North American registry, that rate is low. It's about 1.5%. And so that falls within the realm of the rate of major malformations in women without epilepsy, not on anti-seizure medications. Levetiracetam, again, the rates of major malformations is 1 to 5 when you combine 1 to 5% when you combine all registries, but again, looking at the North American registry, that rate is much lower. And these two, lamotrigine and levetiracetam, are the top two medications in use in the United States for women with epilepsy for use in pregnancy. Topiramate still does have the increased rate of oral clefts. Again, across all registries, it's totaling about 4.7%, although there is a wide variability across registries, and more numbers really still are needed. We're still in the 400 range, 400 plus range for pregnancies in all the registries. And this is also noted to be a dose-related effect, so that if the dose is higher than 100 milligrams per day, the relative risk is about 5 times versus less than 100 milligrams per day when the relative risk comes back down, 1.64 odds ratio. And carbamazepine, also there are dose-dependent statistics for carbamazepine, lamotrigine, and Depakote, really, or valproic acid. Really, there is no practical therapeutic dose which is acceptable, but I'll talk a bit about that because, of course, there are many women in this country and internationally who are on valproic acid therapy and will be afraid or not desire switching medications, or it's not feasible to switch medications in them. But in carbamazepine, if the dose is less than 400 milligrams per day, there's a 3.4% major malformation risk. If it's greater than 1,000 milligrams per day, that goes up significantly to 8.7%. Lamotrigine, and this was a signal that was caught early on by the Australian registry, but it does hold out still when looking at doses across all the registries. If the dose is greater than 300 milligrams per day, there is a 4.5% risk of major congenital malformation, and this is in the first trimester. And whereas if it's less than 300 milligrams per day, this falls down to near the regular rate of malformations. And again, with valproic acid, if you're talking about doses less than 700 milligrams per day, which really are, that dose is not going to control many women with epilepsy, but the risk is about 5.6%. If you go up even between 700 to 1500 milligrams a day, we're up at 10.4% major malformation risk, and even higher with doses greater than 1500 milligrams per day, which is the dose, of course, for many people who are on valproic acid. So really, for a woman with epilepsy, the target dose, as we've said before and as is in the guidelines from the AES on treating women with epilepsy during pregnancy, the target dose is the lowest dose that controls that woman's epilepsy in monotherapy, at least in the first trimester. And polytherapy has become somewhat more acceptable if necessary after the first trimester. I mean, it is acceptable after the first trimester. I've done that myself many times because it is necessary at times, and it really depends on the anti-seizure medications. The best combination, as I mentioned, are those with lamotrigine and levetiracetam. The worst combination would be including topiramate and or a polytherapy with valproic acid. Certainly the two combined would be a very bad combination. And major malformations in polytherapy also depend, as I mentioned, on the dose of the anti-seizure medication. So that is, if I'm just giving update on best practices in women with epilepsy during pregnancy, many of them are similar to what have been in the guidelines. We actually are due for an update in those guidelines. The last was in 2009, and then there was a small update in 2013, but we're due for an update on guidelines with women with epilepsy and pregnancy. But it's important to follow lamotrigine levels or levels of the anti-seizure medication, but especially with the two most popular, lamotrigine and levetiracetam. Lamotrigine is cleared by glucuronidation, which is highly induced by estrogen and even HCG early on, and occurs in about 79% of women with epilepsy. So it's imperative to have an idea of the pre-pregnancy level which controlled that woman's epilepsy and check levels monthly during the pregnancy if possible, so that you can continue to aim for pre-pregnancy levels. And, it's a little bit of a guessing game, but seizures really are thought to occur when levels drop to less than 25% of the previous control level. And that seems like a lot, but this can happen precipitously. It starts in about 6 weeks. And that's a lot of times before a woman even knows she's pregnant. That's why when my young lady patient, who's the nurse, contacted me and said she had something unusual and she had been well controlled for some time, I immediately thought she was pregnant. So think of this when you have a woman of childbearing age on lamotrigine. You may have to, during the course of the pregnancy, increase the dose to 200 or 300%, by 200 to 300%. And I just wanted to mention this new information about cardiac conduction comes into play here, because I will tell you, I have had a patient who did have a fetal demise in the third trimester of her second pregnancy. She was on lamotrigine with her first pregnancy. It was very difficult to keep her lamotrigine levels in her previous therapeutic range. And I pushed the dose, and she had a fine, healthy baby with her first pregnancy. Her next pregnancy, which was not actually her next pregnancy, she did have miscarriage. And then with the next pregnancy, she had the fetal demise in the third trimester, which was devastating. And then she had a next pregnancy. I was a little worried about increasing the lamotrigine, but at that time, really and still there's really no reason to suspect that a fetal demise would be due to lamotrigine. She again had a fetal demise, this time in the second trimester. Again, just absolutely devastating. She was able to tell me that that child was perfect and had no malformations. So with her next pregnancy, at that point, I changed the strategy. And even though I didn't have any, this was all before we had information about cardiac conduction, but even though I didn't have any reason to suspect it was the lamotrigine, I felt that it had to be. And so in her case, I added a second anti-seizure medication after the first trimester, and that was levetiracetam. And she did well and had a beautiful girl, second baby girl. So just to emphasize that you really must treat every patient individually. The other thing to remember, especially if you've had to do this 200 to 300% increase, is that those levels change just as precipitously postpartum. Because this is a hormonal change. So it does not take the usual 6 weeks for all the physiologic changes to go back. This is direct hormonal effect. And so you do have to remember to start tapering the medication back. I actually decreased the dose to half of the maximal dose during the third trimester to half that dose within the first 2 to 3 days. Certainly within the first week postpartum, I have decreased. And within the next 2 to 2.5 weeks, you should be tapering that woman down to the dose that you want to leave her on. And I say that because you should probably leave patients on a slightly higher dose of whatever anti-seizure medication postpartum, because they're going to be stressed, they're going to have sleep deprivation and increased risk factors for seizures. So now the bit of update that I have on the cognitive teratogenesis, this actually, which is due to valproic acid, and that is the only seizure medication at this point which does have a known effect on cognitive IQ and cognitive function. The MONEED study by Kempfer-Metter et al., they did show that children at 6 years of age of women who were on valproic acid during pregnancy had significant decrease in IQ compared to children of women with epilepsy on other anti-seizure medications. And lamotrigine, carbamazepine, and phenytoin were the others in that particular study. More recently, Christensen et al., Jakob Christensen of Denmark, has done independent reviews of several women, hundreds of women, and looked at not only the cognitive outcomes, but neurodevelopmental outcomes, including psychiatric outcomes and autism. Again, valproic acid was the only anti-seizure medication causing significant decrease in language and math performance in school-age children. Now, I don't know that that's 6 or 7 or 8. He did mention school-age children, so I assume it is in that same range, and also showed an IQ decrease of 7 to 10 points in other review of his data. Valproic acid is also the only anti-seizure medication in his studies out of Denmark that have been shown to cause autism spectrum disorder in 4% of those children, and ADHD in 11%. And I've listed some of his reviews there, but he has done remarkable work looking at this in women with epilepsy. And the other anti-seizure medications are listed here. It was carbamazepine, clonazepam, oxcarbazepine, lamotrigine, and phenobarbital. Sorry about that. With the newer anti-seizure medications, as I've mentioned previously, maybe oxcarbazepine also has a very good profile, and I think in Canada, oxcarbazepine is also actually used second most often after lamotrigine rather than levetiracetam. 1.6% risk of major malformations in the North American registry, but we really still have too few numbers in all the registries for these newer medications. Zonisamide, again, 1.5% in the North American registry. It's actually much higher in some of the other registries. There's a wide variation, up to 13% in some of the registries, but we definitely need more data. Just to note, the North American registry has 90 pregnancies out of the 138. So we really have the most numbers in the North American registry, and with a low rate of major malformation. I have several patients that I have taken through pregnancies on zonisamide and topiramate, and fortunately I've not had any issues. Lacosamide, we need more data. We really only have 64 people in the women in the North American registry, and we really don't have, it takes about 50 at least people to start, or women to start seeing some trends, but we really need much more data. And we don't have info on perampanel, cenobamate, brivaracetam, or eslicarbazepine. The other thing I want to mention, although it's not a major malformation, small for gestational age was, and small infants at birth are noted with topiramate and zonisamide more. And also polytherapy is associated with a higher rate of small for gestational age, but seizures during pregnancy do not correlate with small for gestational age. So for some future directions, I mean, obviously we need to get more data and collaborate. I think this is fantastic to collaborate with all the registries, and that was the trend at the American Epilepsy Society, and that should continue. That's really the only way we're going to get meaningful numbers in the near term. Pharmaceutical companies, pharma can help by providing their own anti-seizure registries, and that's why lamotrigine actually had, there's so much data, because when they got their approval, they started their own pregnancy registry, and so we have from 1994 on, and that's why we have better numbers for that particular anti-seizure medication. The other thing to remember, because I didn't really go over all of the guidelines for pregnancy in women with epilepsy, is folic acid. And to remember that folic acid is important before conception, because really the anterior and posterior neuropore of the neural tube close very early on, before a woman even knows she's pregnant with the anterior neuropore. At 26 to 28 days. So we really need folic acid to be around in good supply, maybe within the 3 months before a woman conceives. And so in order to allow that, you should have women of childbearing age taking folic acid. What's not known is what exactly is the optimal dose. And because there may be adverse effects at higher doses, although there's no real data to support this either, but that has been questioned. I think we should I've changed my practice because of that, and I put women of childbearing age on 1 milligram of folic acid per day, and if they're actively planning pregnancy, I'll go up to 2 milligrams per day. Um, I used to go up to 4 milligrams per day. And I still do in some of my older patients who have had pregnancies and knew that they were to go up to 4 milligrams per day. They still do that. But if I do go up to that high a dose, I will take it back down after the first trimester to 2 milligrams, because now you've gotten through the risk of neural tube defects. And I think the higher doses are problematic, possibly in the third trimester and in the early postpartum uh, period when there may be breastfeeding. So the lowest dose really should be 0.8 milligrams. And again, I use 1 milligram per day and increasing that to 2 milligrams per day, which I do keep on board during breastfeeding. Um, and really, there is no woman of childbearing age who should be on valproic acid at therapeutic doses. Although, as I mentioned, there are many women who are on valproic acid, they're well controlled, and they do not want to risk having breakthrough seizures, especially if you're planning pregnancy, because that could be months and months, even years. So you have to look at everybody individually, and I would be sure to counsel the patient on all of the risks of not only major malformations, but cognitive development, the risk of psychiatric disorders, autism spectrum, ADHD. Those are real considerations now. So switching gears again, there were so many things I wanted to talk about, but I tried to bring up topics that I thought would be pertinent and applicable to practitioners. And one thing I wanted to mention was optimizing the care and the treatment of the older adult with epilepsy. And of course, that's important because currently 17% of our population is greater than 65 years of age. And by 2030, it's going to be 20% will be in that category. So just to remind you, the prevalence of epilepsy is highest in the elderly because we're including not only those who have childhood onset epilepsy who continue to have epilepsy into their elder years, but the new onset epilepsy patients in the elderly, and the incidence of epilepsy is also highest in the elderly, even higher than in the newborn period and infancy. So 1 in 4 newly diagnosed with epilepsy is greater than 65 years of age, and a person greater than 60 years of age without overt risk factors for epilepsy still has a 1.1% chance of developing epilepsy. And those are statistics which we've heard in other ways. You have a 4% risk of developing epilepsy by the time you're in your 70s. That's another way of sort of looking at the risks as we get older. The problem is the diagnosis is difficult in this age group. From symptom onset to diagnosis can be sometimes years. It's difficult. Only 37% of some were accurately diagnosed, of those with epilepsy in the elderly were accurately diagnosed. And the reasons for this are multiple. There's limited history. A lot of times they're unwitnessed. These seizures are unwitnessed, and the person themselves cannot give much of a history. Even if there is a witness, there's difficulty getting an accurate description. And then there's difficult clinical presentation in the elderly. This is clearly a factor, and convulsive seizures are less often seen in the elderly population, especially at initial presentation. Also, the elderly have many comorbidities, and so seizure symptoms can be mistakenly attributed to one or more of those comorbidities. how many patients have I seen that have epilepsy, but initially they thought it was hypoglycemia or hyperglycemia because they also had comorbid diabetes. And also, the EEG can be much less sensitive in the elderly population. So, some of the differences between seizures in the elderly and what we would call working age adults, an aura is not often as present in the elderly population, 30 to 54% versus 66 to 76% in working age adults. There's many phases to a seizure in working age adults, and that would include progressing to secondary bilateral tonic-clonic seizures or just more complex presentation of seizures. But it's only 24% in the elderly. Generalized tonic-clonic seizures are less pronounced in the elderly. Postictal unresponsiveness, however, is more prominent in the elderly, and again, might be the main clinical symptom, and so that's how things can be attributed to other comorbidities, 45% in working age adults. And then subtle brief confusion really isn't noted in with frequency in working age adults, but it's seen in 18% of the elderly with epilepsy. So one thing that I think is helpful to remember is look for symptoms that are episodic and stereotyped and unusual, obviously, but this can really help you think about epilepsy in an elderly person when you would not have before. And fortunately, there's an 80% rate of seizure freedom with anti-seizure medications. I would say I don't see this, but this is a statistic that is reported over and over again in studies that most elderly patients' seizures are highly pharmacosensitive. I think the reason for this is that I deal with medically refractory epilepsy, and I also have an older population in general, and I have a lot of geriatricians referring patients to me for epilepsy, and inevitably those patients are or become or are in various stages of dementia, and I'll touch on this a little bit as well. So the majority of cases of epilepsy in the older patient are due to an underlying disorder. Stroke is the number one cause of epilepsy in this age group, and that is more often seen than neurodegenerative disease, which is more often seen than tumor, and then finally traumatic brain injury. But as with, I would say, most adults with new onset epilepsy, there is an unknown etiology in about 50% of the patients. And I remember when I was at UT McGovern, as it's now called, UT Houston Health Science Center, we would always argue with our colleagues in the neuro-oncology division at MD Anderson because they always said, no, you're not looking hard enough. There's a tumor in there. So it depends on your population and your perspective for sure. But this is generally, with new onset epilepsy in adults, the etiology is unknown, even with MRI. There's a 2 to 4 times higher frequency of focal seizures. And something which is really important to remember, and I want to stress, which I didn't realize either, is that 3% of those with stroke developed epilepsy by 5 years post-stroke. But more importantly, this is what I wanted to emphasize, the risk of stroke in the elderly with new onset seizure is also 3 times higher. There's a reciprocity there, so that risk of stroke is there with new onset epilepsy in the elderly, and it's actually within the first 4 weeks after onset of epilepsy, so that if you do diagnose somebody early, with new onset epilepsy, they should have a stroke evaluation if they haven't. So neurodegenerative disorders, there's also a reciprocal increased risk of dementia with new onset epilepsy as well by 2 to 3 times, and vice versa. There's an increased risk of neurodegenerative disease with epilepsy onset. I think this is reported to be 2 to 3 times, uh, but I would say that there are other studies that show that this can even be increased. Um, Again, Alzheimer's disease, 10 to 14% will develop seizures, and there's an increased risk of developing seizures if a patient has the ApoE allele. Similar for vascular dementia and onset of seizures, 10 to 14% or so. And other neurodegenerative diseases, 15% of those with Lewy body disease, 3% of those with frontotemporal dementia, maybe a little lower in those with Parkinson's dementia. So some considerations for the treatment of the elderly, as I said, multiple comorbidities. And just don't forget, as we age, renal and hepatic function decreases. So this is a given. You must think about creatinine clearance and checking for hepatic dysfunction. We don't have anything as readily available as creatinine clearance for hepatic dysfunction, but you should be looking. Hypoalbuminemia in this group is also a reason, a consideration in this group. Especially for highly protein-bound medications, which can then cause toxicity if there's hypoalbuminemia in the patient. Genetic factors can still be present in the elderly, and then habits that they may have, such as alcohol use, smoking, also the polypharmacy that is inevitably there with the majority of elderly patients, and remembering about the pharmacokinetic and pharmacodynamic reactions that can happen in that group. Also remember that a lot of elderly are isolated or don't have adequate social support, as would be in a younger adult who is of working age and has their family around them. That's something to consider as well. Other considerations for treatment of seizures in the elderly is falls. We have to remember about bone health and the risk of fractures with falls from epilepsy, or just falls, but definitely falls with epilepsy. And that also is increased risk of traumatic brain injury and hemorrhage, and that risk is increased if they're on antiplatelet agents or anticoagulant medications. There's risk of concussion, of course, with any fall, and then disequilibrium as an adverse effect of anti-seizure medication and its contribution to falls. And I can tell you, this is really a struggle for some of my patients. I have patients that I have on drugs such as sodium channel blockers, like carbamazepine, oxcarbazepine, lacosamide, and I worry, especially in those who have spinal stenosis or low back pain and other back injuries, that I am causing them to have more falls. And that's another reason that I think it's really important to check levels in your patients, because you never know. A lot of elderly patients go in the hospital, and as we know, hospitalists take over in the hospital, and many patients are discharged on a double dose, their home dose, and then whatever generic formulation was given them in the hospital. So really go over all the medications and follow the levels of seizure medications in elderly population as well. The efficacy is fairly similar with anti-seizure medications in the elderly, so you want to choose the medication based on the adverse effects, just as we would with anyone, but probably avoiding those that have a lot of sedation or dizziness. Remember about the risk of hyponatremia which is particularly evident with oxcarbazepine. More frequently, the risk is higher than with eslicarbazepine, which also is probably a little more common than with carbamazepine. Um, Also, you know, you have to consider SSRIs. A lot of patients in this age group are put on SSRIs or are on SSRIs, and that will also lead to hyponatremia. Um, with an additive effect in these patients. The cardiac conduction abnormalities, which now we're all going to be looking out for, I hope. And also remember that the elderly are usually excluded from clinical trials. So it's difficult to know what to expect in this age group because they're not involved in trials and looking at side effects. What anti-seizure medications to use, as I mentioned before, lamotrigine. There's the cognitive mood stabilizing effects, and it's cognitively neutral. Again, watch out for glucuronidation, which you have to check with hepatic disease. Watch for cardiac conduction issues. Levetiracetam is also another well-tolerated medication. Again, watch renal excretion. And I have become in the habit now of getting a BMP whenever I check um, levetiracetam levels, so that you can really correlate that and know if you're heading for trouble because their creatinine clearance suddenly lowered. Um, of course, you have to worry about agitation. Well, what I do with this is also try to switch to the extended release formulations as soon as I can. If they have to go through step therapy, I do it within a few weeks and then get them over to extended release. And I use a bedtime dose initially because of sedation initially with levetiracetam, but people can get restless leg syndrome or insomnia, some kind of hypervigilance as well from levetiracetam. And in that case, I'll switch their extended release dose to the morning and have good luck with that. And that's after they have been on this medication for some time. Zonisamide is a drug that I don't use frequently in the elderly, but I think we should consider it. You do have to remember the risk of renal stones and that it is a diuretic, so there's considerable risk, and you have to watch for that, counsel patients about drinking enough water, avoiding caffeine. Um, but there is good efficacy at probably at lower doses. It's well tolerated at lower doses. It has a very long half-life, as you know. That's why it's a favorite of mine in younger adults and adolescents even. And possibly it may be helpful for those with Parkinson's disease or bradykinesia. Apparently, some have reported in Japan use to help with motor issues in Parkinson's disease. One thing I would caution people that I even forget is that you should be aware that if the patient has a sulfa allergy, they may be allergic and have a cross reaction with zonisamide. And so watch for that. There is a sulfur moiety in zonisamide, and that has happened with several of my patients. And sometimes it's not always what you would expect as a drug rash, but they do have hives and itching eventually. And Depakote, because of inducing tremor, and other adverse effects, can cause a Parkinsonian syndrome, even at low doses, so be aware of that. Maximize the use of gabapentin or pregabalin. I have a little bit of issue with this. A lot of older patients may be on gabapentin or pregabalin for neuropathic pain, or to increase the effect of narcotic agents, and that's why I have issue with its use. But again, they're cleared by the kidney and so easy to titrate and follow in elderly patients. You should use low doses. I have the bias that gabapentin or pregabalin in my experience, seems to worsen temporal lobe epilepsy. Now, there's no study documenting this, but I do feel in my experience that can happen. And so, if I know that this is temporal lobe in onset or the symptoms are more consistent clinically with temporal lobe onset, don't, I really try to avoid these drugs. Also, there are side effects of peripheral edema and third spacing in the extremities and weight gain, which is not readily reversible as it is with valproic acid. So remember about these side effects that people just don't talk about. Um, and the strongest predictor of quality of life in the elderly with epilepsy is seizure freedom and their seizure medication tolerability. One thing I'd like to mention is that stigma has overriding importance in this age group, probably just because of the culture and generation. But in my practice, this can be a problem, especially with older, very successful men who have new onset epilepsy. It's very difficult for them to um, accept that diagnosis, even more, I think, than for elderly women. Um, Also, that can cause to lack of medication adherence, underreporting of falls, seizures, neurologic events. And it's important to know about epilepsy because of the relationship between stroke, dementia, and epilepsy. And this can lead to poor outcomes if we don't recognize the reciprocity of those illnesses. Also, of course, people have fear of losing driving rights or losing their independence, and there's comorbid depression in a high amount in this group. I see I have run out of time. I'm gonna pass by this in the interest of time. Just to mention a couple of things about future prospects. I think we heard some wonderful lectures this morning about genetics, and genetic testing, I think, will become standard of care in the future. It really is difficult to get genetic testing in with private practice patients. I mean, most of these insurers do not want to allow testing, and it's more difficult even with Medicare and Medicaid, but hopefully it will become more affordable and accessible for all. I think one thing, and maybe this was really brought forth in the studies, in the talks of this morning, we really should look at genetic causes in all of those with epilepsy of unexplained cause, especially those with developmental delay or those with developmental epileptic encephalopathies, DEE, because I think that the majority of those have a genetic cause, and we're just at the tip of the iceberg of discovering all of those genetic causes. Still, of course, as you heard this morning, it's difficult because most of the time you're not looking for a single gene mutation. So, but that is something to keep in mind for future prospects. And then newer anti-seizure medications like cenobamate, I think, are really going to be the way of the future of anti-seizure medications. In my practice, I have always tried to use different mechanisms of action when I'm choosing different seizure medications. And cenobamate is nice because it has the two different mechanisms of action, which are both excellent for seizure control. And I think this is maybe going to be something to consider with future anti-seizure medications. Another trend in newer anti-seizure medications may be also using medications that can treat the cause of the epilepsy itself. And I think that has really come to light recently with the use of perampanel in treatment of those with epilepsy and low-grade gliomas, even as they may transform into higher grade gliomas. Perampanel has been shown to have a mechanism of action of inhibiting IDH, which does decrease tumor burden as well. So I will stop there in the interest of time, and um, I'm happy to answer any questions. I'm so grateful.
Great. Uh, um, Now, wait, it sounds like Dr. Thomas is suddenly on mute.
Oh,
Is that true? Are you there?
I'm
Are you
here.
there? Okay, great. Okay, so thank you so much. And there are some comments and some questions, and so maybe we can go through some of these quickly. There's one comment
Okay,
from Dr. Brian Loftus who says North American registry data through October 2021 on the website for zonisamide is now 205 cases, still at 1.5%
right,
versus topiramate 4.8% with 503 cases, zonisamide 200 equal to topiramate 100 for migraine. So let me
right.
just get to some of the questions. The first question is, do you get an anti-epileptic drug level in the morning before taking the meds or randomly?
This is my practice is to get it randomly, but I look at the time that the sample was collected and look at the time of their last dose. And that has always been my practice. And I tend to get levels about the same time every day. But because I do check levels often, I am able to see the trend, and I feel that's better. I've had people go to the lab, and the lab will argue with the patient, turn them away, and say, no, you have to come back fasting or without taking your morning medication. And that's just not the case. I think it's actually more reflective of real life. And honestly, I I really want to discourage holding doses. A lot of
Yeah.
patients don't know when they're going to be able to go to get to the lab, or the lab has strange hours, especially right now in the time of COVID. Labs are overrun with people and tests, and it's just not as easy anymore. So I have never done trough levels.
Thanks. So another question, when do you start to increase lamotrigine once once the patient is pregnant to maintain levels? So, for example, is it immediately after your first low level comes back? Check at the end of the first trimester, and then the second part of that is, given the risk of higher malformations with higher lamictal dosing, um, uh, do you check lower levels to demonstrate lower levels in the first trimester before increasing?
So the first part of the question was, when do I initially check a lamotrigine level with pregnancy?
Yeah. When do you start increasing lamotrigine
Oh,
to maintain
immediately.
levels? Yeah.
Immediately. If you, so this is the reason why you have to plan pregnancy, and this is the reason that there's also in the guidelines, there's a sense that you look at the control over the 9 months previous to conception to get an idea of how the woman will do during the pregnancy. But the reason for that is also to give you time. You should have a good year, if you can, to plan pregnancy, so that you get an idea of the levels that you need in that patient. And then is when you find out what is the lowest level needed to control that woman's seizure disorder. So if you can lower, that's often when I will try to lower lamotrigine doses when I have a woman who's on a higher dose of lamotrigine when we're planning pregnancy. And then I find out what is the lower level. There are some people that I just can't make it with under 300
Yeah.
milligrams, but I I I don't know if I mentioned it when we're talking about polytherapy and adding a second medication after the first trimester. If I'm in trouble and I need to increase that dose, in the first trimester, I will do that because if I'm following the level. However, if I'm having trouble and they're still having seizures faster than I can increase their level, I will add levetiracetam, even if it's in the first trimester after the first 8 weeks. But the thing is, this is a precipitous decline, and it happens at 6 weeks. And there must be a decline also with a HCG, so that immediately I am working to get that woman's level up. And as I said, you can really increase 200, 300%. But the times where it's most needed is in the first trimester, early there. Towards the end of the first trimester, I would say, and then towards the end of the second trimester, and then again in the third trimester as you're increasing. So that's why, sorry, as you're heading towards the finish line, I would check levels monthly. And again, seizures will occur when you're less than 25% of the level which normally controls that woman.
Thanks. There's also a question about cardiac patients. So this question is that cardiac patients are usually on diuretics, which may cause arrhythmias aggravated by lamotrigine and other sodium blockers. In some refractory seizures, it may not be possible to stop the target AED. So could you comment on that and tell us what your thoughts are? So it really
Well,
focuses
yes.
on, the use of the concomitant use of diuretics and lamotrigine.
Um, well, I'd say that the first thing is I would get a cardiology consult and have that cardiologist work with me with these drugs.
Mhm.
And that a lot of my patients already have cardiologists. I'm going back now and looking at their EKGs, but I think if they don't already have risk, one of those set of circumstances that I outlined for arrhythmia, I think you have to try and continue to use your best clinical judgment and use your medications to prevent seizures, but be alert for those AV blocks, sick sinus syndrome. I mean, we have got to be more sensitive to those kinds of issues. Um, Even, as they said, even those who have risk factors for heart disease. So, I think we need to be working with our cardiologists, but we need to continue to treat our patient in our best clinical judgment unless you have these specific set of circumstances. And then you would be working with the cardiologist, hopefully, anyway.
Great. There's a question about how often you see or consider drop attacks in the elderly as a common ictal phenomena.
Uh, I mean, hardly ever. I don't think that's something that we see in the elderly. I think we see a lot of falls and maybe a lot of slumping or missteps if somebody is having a seizure with a subsequent fall. Um, I I don't think drop attack. That is something that's in your realm, Dr. Mizrahi, with
Right. Yeah,
yeah, in the usual epilepsies that we see it. But I
yeah.
will say that there are many patients that fall or that come in with bruises or raccoon sign, and especially in this elderly population who are worried about stigma, there's always an explanation. There's always, I was walking the dog and I tripped down the
Yeah,
step. I was pushing the garbage pail. I think we have to be very careful there. I think we have to really look because, again, seizures are different clinically in the elderly And I think there is such a strong desire to downplay anything because of stigma or because of the fear of losing independence and, right to drive. But any older person that comes in my office with large bruises on their hips, ribs, raccoon sign, you have to directly face that head on and start counseling them.
So just one more in the interest of time, and this is about tremor. So isn't the tremor on Depakote kind of fast and a fine or low amplitude tremor? It's not really a typical Parkinson tremor, at least not in the experience of the person asking this question. So are there other Parkinsonian-like symptoms associated with this?
I believe so. This was not something I have seen in my practice, but movement disorder specialists have said that there is a bradykinesia, um, and I assume the tremor is also part of that with the use of valproic acid in older. I use valproic acid in older patients, though. I don't seem to have that problem. It's actually younger people that seem to be more upset by the tremor. But yes, I
Great.
would say that it's very different than a resting, 4 to 5 hertz
Great.
tremor that you see with Parkinson's.
Great. Great. Well, there are a couple of other comments and questions, but we're so far over time. Thank you so much for this really wonderful discussion. They were really very important, focused discussions that I do think are so important in people's practices. And we really greatly appreciate this as a really wonderful contribution to this afternoon session. So
Thank you
with
so
that,
much. Thanks for having me.
yeah.